at University of Medical and Health Sciences, Jamshoro, Pakistan, followed by specialist training in hematology at National Institute of Blood Disease, Pakistan. She continued her academic and clinical career at NIBD, where she served as consultant hematologist, faculty member, and later as professor of hematology and head of Department of Malignant Hematology. Her primary research interests focus on hematological malignancies. She is currently serving as a consultant hematologist at the Royal Blackburn Teaching Hospital, UK, while also maintaining an academic affiliation with NIBD, Pakistan. Please welcome Dr. Nida Anwar.
Dr. Nida, you are on mute. Please unmute yourself. Oh, yeah.
Yeah.
We can see you. Thank you.
Yeah. Thank you very much. Shall I start?
Yes, please.
Yeah. Thank you very much for giving me this opportunity, Dr. Zanara Shah and all the colleagues. This is Dr. Anwar. I'm a consultant hematologist currently working at Royal Blackburn Teaching Hospital, UK, and faculty at National Institute of Blood Diseases and Bone Marrow Transplant, Pakistan. So today we're going to talk about the management of chronic lymphocytic leukemia. Before we embark on the management, chronic lymphocytic leukemia, it's a clonal disorder, a lymphoproliferative disorder, which is characterized by the proliferation of B lymphocytes. It's usually most of the times an incidental findings which come across either before the surgery or just a routine presentation on the complete blood counts with raised WBC counts and the lymphocytes. Before considering the treatment, it is very, very important to have these considerations before starting anything. Most of the times, it just requires a wait and watch approach because all CLL does not require the treatment. And there has to be a very careful consideration of various factors, such as patient-related factors. In the patient-related factors, CLL usually presents at an elderly age as far as the Western world is concerned. The median age of presentation is mostly the 60s and the 70s. So this is very, very important to see the patient-related factors such as the patient's performance status, comorbidities, concomitant medications that the patient is taking, and most importantly, the patient preference, because most of the treatments, some are fixed duration treatments, some are indefinite treatment. So this is very, very important to carefully evaluate the patient's needs, the patient's expectations, and all these factors. Then comes the disease-related factors. So it is very, very important to evaluate what is the prognostic parameters. Is the patient symptomatic or not symptomatic? What are the predictive findings? What are the biomarkers? What are the prognostic factors like TP53 mutation, disruption, deletion? What is the IVHG mutation status? So this is all those disease-related factors that have to be carefully evaluated before you embark on the treatment. And in addition, this is very, very important that you evaluate the previous responses and toxicities. Is the patient having de novo presentation, any history of previous chemotherapies, radiotherapies, and the impact of the treatment that you're going to offer on the cellular and humoral immunity. So all these factors really do matter and impact and influence your therapy choices. As we already discussed, that not all CLL need treatment. If the patient is not having any criteria for the treatment, you just continue with the watchful monitoring, because undue treatment causes more toxicity rather than the benefit. So there has to be very important consideration of the patient-related factors that we discuss, the best supportive care, because as we discuss that it's usually an elderly presentation. So sometimes the initial presentation of CLL could be just like autoimmune hemolytic anemia or the thrombocytopenia. So best supportive care with sometimes the patient is having history of recurrent infections. So the best supportive care in terms of the patient needs, whether it be the transfusion or it would be any treatment of the immune-mediated presentation, or the best supportive care that also comes in the domain. It's very, very important. Most importantly, especially in the Western part of the world, enrollment in the clinical trials wherever appropriate. So screening for the TP53 disruption, the deletion and mutation is very, very important prior to each line of treatment. It's recommended whenever you start the treatment with each line of treatment, because these genetic abnormalities remain a very high risk group of patients, even in the area of targeted therapy. Additionally, the IgHV immunoglobulin heavy gene mutation analysis should be performed to identify those subgroup of patients who do fairly good and may be functionally cured if the patient is comparatively fitter and younger. And they can be offered a chemoimmunotherapy like fludarabine, cyclophosphamide, rituximab, that is FCR, and have excellent durable responses, especially with the fixed duration 12-month treatment of venetoclax and obinutuzumab that we'll be discussing later on. So generally, the frontline treatment of less fit patients, or rather I would phrase it, or those patients who we see they are unsuitable for the chemoimmunotherapy and have intact TP53, that is, they have no deletion or mutation of TP53. So the options include the ibrutinib, that is BTKI inhibitor, acalabrutinib, another second generation BTKI inhibitor, and venetoclax obinutuzumab. So all the trials that I mentioned, that is Resonate, Alliance, Elevate, and all these CLL14 studies, they all have shown a superior progression-free survival, because the main goal and aim of treatment that we opt to get out of it is not the cure. It's to get a better progression-free survival, overall survival, and health-related quality of life. And all these frontline treatment offer the superior progression-free survival as compared to the previously given treatment like chlorambucil and various other treatments that were previously given for CLL. When we talk about these frontline treatments, specifically the combination of venetoclax and obinutuzumab have some potential advantages as compared to the BTKI individually in combinations, because this fixed duration treatment, the studies have shown that they have higher MRD rates, responses, as compared to the BTKI treatments. So for those patients who have intact TP53 with no mutation and deletion, but are rather fit as compared to the frail or less fit patients, one of the option of chemotherapy that is still viable is the combination of fludarabine, cyclophosphamide, and rituximab, that is FCR. That still remains a viable option for those patients who are fitter, younger, who do not have TP53 mutation, and specifically those who have mutated IGVH, because it infers the better prognosis. So the BTKI and BCL2 inhibitor, that is venetoclax. So currently the frontline treatment with ibrutinib and acalabrutinib, they do not have, if we talk about the UK, because since I've been practicing recently at the UK, so they both are approved, the ibrutinib and acalabrutinib. However, when it comes to the funding, these do not have NICE approval to be used in younger fit patients, and only those patients who have TP53 disruption, they have NICE approval for these two BTKI inhibitors. So the NICE approved for frontline treatment options for all patients with CLL and those with TP53 disruption include the combo of venetoclax obinutuzumab. The venetoclax monotherapy is offered where the BTKI is deemed inappropriate or contraindicated. So the combination of BTKI inhibitor and BCL2 inhibitor with or without anti-CD20 antibodies are highly effective first-line combination treatments. And both these continuous treatment with acalabrutinib monotherapy and the 12-month fixed duration of venetoclax and obinutuzumab, they both are now NICE approved in the UK. However, the frontline single-agent monotherapy is NICE approved and funded only in case where we have TP53 disruptions. It's very, very important to carefully review the medications that the patient is on, because before deciding the type of treatment, the concurrent medications should be carefully reviewed, and especially if the patient is taking strong CYP3 inducers or inhibitors, and this is very, very relevant when you start the treatment with BTKI inhibitors. Also, it's very important to carefully evaluate the anticoagulation, because if the patient is on warfarin therapy or antiplatelet therapy, you need to switch the patient on alternative anticoagulation, because warfarin is relative contraindication, and that is because the BTKI inhibitors do impair the platelet function. So this is very, very important to carefully review these medications. Moreover, the BTKI inhibitors have complications like hypertension and cardiovascular abnormalities. So this is very, very important to carefully review the patient factors, especially the cardiovascular status of the patient, as these BTK inhibitors do have the cardiovascular complications. They are more pronounced with ibrutinib as compared to the acalabrutinib or zanubrutinib. It's very, very important that's the patient choice, because it is very, very important to know what is the patient expectations, what are the patient priorities. If the patient wants to opt for fixed duration therapy, or patient is fine with the continuous therapy, because this dilemma of being diagnosed with a cancer, and with especially in the western part of the world, to know that you have to be on continuous therapy which has to be go on. So these are the factors which have to be carefully considered and spoken to the patient in detail. And individual patient compliance, what is these are elderly orders, so what are the patient's living conditions, what is the supporting status, what is the family status. So individual patient compliance, the age, especially for the younger fit patients, they tend to require a fixed duration treatment rather than to be on the treatment for a longer time. And the effect of the treatment on quality of life, that's very, very important. Patient wants the IV therapy, or patient is okay to come up for the frequent hospitalization visits, or patient is okay fine with the oral therapy. So all these factors are very, very important. And then especially with the chemoimmunotherapy option like FCR for younger fit patients, even though they have immunoglobulin mutated status and no TP53, and they can go for this FCR option. This is very, very important to let them know that with these options, there are long-term risk of secondary myeloid cancers. They should be carefully discussed with the patient in general. So this is a reference treatment algorithm from British Society of Hematology guidelines. So it's a very beautifully concise summary for treating of CLL. This that all CLL do not need treatment. Firstly, we have to evaluate if there's any indication for the treatment. So International Working Group of CLL criteria for the treatment include either the patient is having constitutional factors, or progressive hepatosplenomegaly, progressive cytopenias, or progressive cytopenia that are pertinent to the CLL, progressive lymphadenopathy. So if the patient does not fall into any treatment criteria, so the approach would be to just continue with the watchful monitoring. No treatment is required. But if the patient is or do possess any features of the treatment criteria, then this is very, very important to screen the patient for two things. One is TP53 disruption and IVGH mutation status, where it's available. It's not available everywhere, but TP53 disruption has to be seen. Then, as we discussed, consider the comorbidities, the concomitant medications that the patient is on, the patient preference and expectations, and consider enrollment into the clinical trial at all lines of treatment wherever appropriate and accessible. And if the patient is having TP53 disrupted, then the preferred options are acalabrutinib in the first line plus minus obinutuzumab. As we discussed, another option is ibrutinib, and if the TP53 is disrupted, then the alternative option, when these are not applicable or not workable, then another option is combination of venetoclax obinutuzumab or venetoclax monotherapy, and that is deemed appropriate if the patient is having any contraindication to BTKI inhibitors. But if for those chunk of patients who do not have TP53 mutation, who have no comorbidities, who have mutated IVHM, then and potentially if it's fine to give for the chemoimmunotherapy, then the first option is FCR. Or if it's not workable, then the frontline another option is venetoclax obinutuzumab combination as well. So at all lines of treatment, if the patient is high risk and harbors the TP53 disruption, we have to keep transplant in mind. It doesn't come in the frontline option, but specifically if the patient fails the first line of treatment with BTKI inhibitor or BCL2 inhibitor, or then you have to keep transplant in mind. Refer the patient for the transplant, discuss with the transplant team, even though you start with second line treatment, but this warrants that this is a patient of high risk disease who've not responded either to the frontline treatment or has TP53 disrupted. When we come to the choice of second line treatment, again, if the patient is having TP53 disruption, the preferred option is combination of, in the second line, is a combination of venetoclax and rituximab, or alternative BTKI. For example, in the first line, if you get ibrutinib, then another alternative BTKI like ICAL or zanubrutinib. So this is another option. And the less preferred options, if TP53 disrupted, again, is another BTKI inhibitor or a combination of VR or monotherapy if BTKI is deemed inappropriate or unsuitable. For TP53 intact, choice of second line treatment is again BTKI inhibitor or combination of VENAR, that is venetoclax and rituximab, and consider allotransplant for those suitable patients who either fail to the second line of immunotherapy or BTKI inhibitor or BCL2 inhibitor, irrespective of the TP53 status, before you even start with this third line treatment. So, and this is very, very important. If the patient is having such refractory disease, not working first line, second line, then do refer the patient for sequencing prior to any treatments. And then again, we have combinations of venetoclax, combinations with BTKI inhibitors, or even venetoclax retreatment can be offered even if the patient was given previously venetoclax in the first or second line treatment. Or another combination is idelalisib rituximab. So it's a summary of recommendations. So the NICE approved option are combination of venetoclax obinutuzumab or acalabrutinib. Then we have NICE approved treatment options for those patients who are fit with TP53 disruption. They include again acalabrutinib, ibrutinib, or venetoclax monotherapy for those who have contraindications for B cell receptor inhibitors. And for those fit patients with intact TP53 mutated IVG, FCR remains an acceptable option. Previously, bendamustine, rituximab, or even chlorambucil obinutuzumab used to be an option for fit patients, but these options are now obsolete and are no longer used in the frontline setting. So again, NICE approved, not NICE approved option, combination of acalabrutinib or obinutuzumab as a frontline treatment for patients with or without TP53 disruption, or ibrutinib monotherapy in frontline option, but this is not NICE approved and not funded in the UK. Now we come to the relapse or refractory cases. This is very, very important. Again, whenever there's a disease relapse, the most important factor is to again re-evaluate, re-biopsy, reassess, restage. And this is very, very important to have an open discussion with the patient, evaluate the previous treatment, the previous compliances, what are the current status, what is the current organ function, are we dealing with CLL or there's a transformation to Richter's. These are those important factors. They are very, very important to consider when we are dealing with relapse or the refractory cases. And there has to be an individualized approach, taking into account, as we discussed, patient, treatment, disease-related factors, and toxicity profile of the previous treatment that the patient had. So the current licensed therapy in relapsed CLL are again BTKI inhibitors, that is ibrutinib, acalabrutinib, BCL2 inhibitors, that is venetoclax monotherapy, or in combination with rituximab, that is VR combo, or the phosphoinositol kinase inhibitors, that is combination of idelalisib and rituximab, though practically this option is less preferred in UK due to complication that we'll be discussing later on. So again, acalabrutinib monotherapy, why? Because this basically demonstrates a benefit of progression-free survival in relapsed cases as evidence of the SN trial, demonstrating an overall response rate of 81% and 12 months progression-free survival of 88%, which is quite better as compared to the previous therapies. And it also demonstrates improved progression-free survival, especially in cases where there's disrupted TP53 and even unmutated IVHE mutation status subgroups. Again, in the venetoclax and rituximab combination in the refractory setting, first preference is that it's a fixed duration therapy of 24 months, 2 years, and it also demonstrates progression-free survival and overall survival benefit as compared to the previously used bendamustine and rituximab combination and as evidence of Mirana trial. Then the ibrutinib basically demonstrates superior efficacy in relapse and refractory settings of CLL as compared to the previously used single agent ofatumumab, as evidenced by the Resonate trial, with overall response rate of 91% and complete response rate of 11%. Then we discussed that combination of idelalisib rituximab. The phase 3 trial basically demonstrate the standard chemoimmunotherapy and as compared to the standard chemoimmunotherapy. Idelalisib demonstrated an overall response rate of 83%, however demonstrated the progression-free survival of 19.4 months and overall response rate of 40.6 months compared to rituximab monotherapy. However, practically this combination remains less used treatment options because it's got a lot of immune-mediated complications and infectious complications like colitis. So it's practically a less preferred option in the UK. So the summary of recommendations for the relapse or refractory cases is targeted inhibitors in form of BTK inhibitors, BCL2 inhibitors, either alone or in combination with rituximab. In England and Wales, ibrutinib, acalabrutinib, and venetoclax with or without rituximab are currently approved and commissioned for this indication. For patients relapsing after BTKI, it's in general that switch the combo. If the patient was previously given BTKI inhibitor, switch the patient to offer venetoclax. If initially venetoclax, switch the patient to alternative treatment like BTKI inhibitor, irrespective of the TP53 status. So for patients relapsing following fixed duration of venetoclax-based therapy, that is VR, again, as we've discussed, that switch the combination to BTKI inhibitor or offer a single-based venetoclax-based therapy depending upon the reasons for the intolerance. Now coming to the role of allogeneic stem cell transplant and CAR-T, as we've discussed, allogeneic stem cell transplant does not come in the frontline setting, but it's very important. The decision for the transplant should be reserved for those high-risk diseases, and all the factors that need to be considered are what is the remission status, the patient age, biological age, chronological age, patient's performance status, the comorbidities, the patient preference, the patient's support, donor status, and availability of alternative treatment. These are all factors that has to be carefully evaluated, and identification of those high-risk group of the patient and early referral to the transplant team. This is very, very important to search for the donor and all these aspects. The transplant eligible chunk of patients are those patients who are either refractory to chemoimmunotherapy or they carry TP53 disruption, or if those chunk of the patients who relapse following at least one targeted agent. Alternative immune effective cell therapies to allogeneic transplants, that is CAR-T cell therapy. This has been evaluated recently in the clinical trials for the last 10 to 15 years, and initial success was reported back in 2011. However, it offers a complete response rates of 20, it's variable from 25 to 65% in heavily pretreated patients. The results are not those robust, and some results are very disappointing. And the main reason is CLL-associated exhaustion of autologous T cells. So it's not a very robust treatment at present. It's still in the clinical trials. So the summary of recommendations is allogeneic stem cell transplant is treatment option for suitable patients with high-risk disease CLL. And this high-risk includes either if the patient has failed 2 out of 2 chemoimmunotherapies or BCR inhibitor or BCL2 inhibitor therapies, irrespective of the TP53 status, or if the patient has either failed and harbor TP53 disruption. And as discussed, CAR-T therapy is currently an option in the clinical trial. In CLL, there's a progressive immunodeficiency. So this is very, very important that the patient has to be educated for the vaccination at the very start, as there have been impaired responses to vaccination, including influenza, pneumococcal, hepatitis B, and varicella zoster. So for all patients who of CLL with a history of serious or recurrent infections, antimicrobial prophylaxis is very, very important, specifically if the patient is on targeted agents. Because the patients with, and specifically the patients with relapse on refractory diseases, they do suffer from secondary immunodeficiency. So especially when the patient has relapse or refractory disease, it's very, very important to start with the antimicrobial prophylaxis. The patients who are taking BTKI inhibitors, continuous BTKI inhibitors, PJP prophylaxis is recommended throughout therapy for at least the first 12 months, or when the risk of first 12 months when we have a very high risk of atypical infections. For relapse refractory patients, specifically who are on the fixed duration treatment like VENAR, in the relapse refractory setting, prophylaxis may be considered for at least 6 months, even after the end of treatment or when until there is CD4 T cell recovery. So the recommendations are all patients should be offered vaccination at diagnosis and avoid the live vaccinations. Vaccinations against pneumococcal infections include the both Prevnar followed by 2 months by Pneumovax vaccination. Functional antibodies should be checked every 6 weeks later in those with history of recurrent or serious infection to accelerate access to the immunoglobulin IVIG. And vaccination should be repeated after 5 years. The patients who have recurrent or serious infections should be recommended on prophylactic antibiotics. PJP prophylaxis should be considered in patients at risk, and specifically the patients who have low IgG, that is less than 4 grams per liter, recurrent or serious infection despite 6 months of after being given prophylactic antibiotic and documented failure to respond to vaccination, should be offered immunoglobulin replacement therapy. The annual flu vaccination is recommended for patients and the household members as well. However, the COVID vaccination is recommended in all patients and household members. However, routine testing for COVID-19 in general antibody is not currently recommended in the UK. I thank you all for your patience. If there are any questions, I'm happy to take. Thank you very much.
Thank you so much, Dr. Anwar, for a wonderful presentation.
Thank you. Any questions?
I don't see any questions in the chat box. In your preference, Dr. Anwar, do you have any preference? Like, do you start first head like on acalabrutinib, or do you start them on ibrutinib and then switch later if they are not tolerating it?
Yeah. So if I talk about my practice in Pakistan, to be honest, we used to prefer ibrutinib because it is less, it was cheaper as compared to acalabrutinib. And access of ibrutinib was relatively easy and was registered brand. In Pakistan, we didn't used to have registered brand of acalabrutinib. So when it comes to the Pakistani practice, we used to prefer that. However, in the UK and in Pakistan, the median age of CLL was younger as compared to what we see in the Western world. However, in Western part of the world, since I've been practicing in the UK now, so if the patient has TP53 mutated status, then ibrutinib is a nice funded option. And specifically, the cardiovascular factors are very, very important. We have to be sure if the patient has any cardiac comorbs, then that is also a factor that we prefer acalabrutinib as compared to, the ibrutinib, because acalabrutinib is less cardiotoxic as compared to ibrutinib. So these factors are very, very important. The access, the funding, the TP53 mutation status. In general, if you're practicing in the West, things are different when you're practicing in Pakistan. That is the difference.
And do there also they have to admit for venetoclax dose ramp up?
Yeah, because venetoclax ramp up, if we talk about the standard practices in the UK, yes, there's a ramp up. You gradually ramp up the doses because there's a risk of tumor lysis. In Pakistan, things were, relatively different. We used to give the combination of Veno to have a fixed duration treatment that was an edge, but venetoclax was first. Venetoclax again was not available as a registered product because it comes in the baggage. So sometimes we used to give the antifungal treatment as well to reduce the dose of, venetoclax 200 milligram. These are the little. It's not the standard of care, to be honest, but sometimes in Pakistan, things become very difficult. However, in the UK, you follow the standard practices, and there's a ramp up of careful monitoring. We admit the patient during the first cycle, and then we observe, because initially venetoclax is not given. Initially, we give the BTK inhibitor, and then there's a combination, and then there's an escalation. So your standard protocols are followed as it is. Things are different in Pakistan.
Thank you so much. I don't see any questions in the chat box. I have one question. I think someone asked. Do you recommend venetoclax 10 milligram with voriconazole 200 milligram BD for patients having financial constraints? That's from
Not
Dr.
10
Mehdi
milligram,
Khan.
100 milligram. 100 milligram.
I
You're
think
talking
it's a
about
typo, 100
venetoclax, yeah?
milligram.
100
Yes.
milligram, yeah.
Okay, that was the question. Thank you so much. If we don't have any more questions, I think we can sign out.
Thank you very much. Thank you.